The considerations that I offer you today in terms of trauma-informed care are summed up in your packet. First of all, that virtually every person that we work with in our systems has an adverse childhood experience count that would put them into the harm category, the at-risk category. And that the negative things that happen in childhood don't just affect a person emotionally, but also from a health standpoint. How we interact with people can either restore hope for them or hurt them more. So we have to develop ways to mitigate the harm that we do to people. One of the ways that we recognize that an organization has to change in becoming trauma-informed is that we have to really decide how many rules are absolutely necessary for people to be physically and psychologically safe within that setting. And that is a really hard thing to do because, for example, long years in psychiatric nursing, we know that people come to the hospital to get better, and we have a belief that the things that make them get better are all those structured groups and activities that we offer to them. So keeping people out of bed and keeping people on their schedule, going to groups, has been a huge part of my job as a psychiatric nurse since the late 80s, and then to help other people do the same thing. But sometimes the schedule is part of a person's trigger. It doesn't help them. You know, every person cannot handle, while they're in behavioral health care settings, the same amount of stimulation, the same amount of intervention, and yet it's really not individualized. We really think everybody should get individual therapy, and everybody should get group therapy, and everybody should get family therapy, and everybody should get therapeutic recreation therapy. And the need to keep to that schedule every day produces opportunity for every one of our patients, for example, here at Clarity, an opportunity to not be able to fulfill the transition. So for a child with emotional regulation problems, cognitive flexibility problems, executive functioning, especially with transition problems, social skill deficits, that schedule can be just as much of a trigger as can be a day at school that might have brought them here. So organizations also have to make decisions about whether they are going to have a level system. There are dozens of decisions that have to be looked at in a new and different way when an organization takes on a conscious awareness of the implications of trauma-informed care. It's not just enough that we acknowledge in our own minds that a person is affected by trauma negatively, not just at the time of the trauma, but forever, but we have to act on that. And we act within, in most cases, organizations that sometimes don't give us complete freedom to do whatever we want. And we also, when we work in settings where we work with groups, which a bunch of us do in this room, we also have to recognize the impact of when we work with one, that impact on the many. One of the reasons that I think the Adverse Childhood Experiences Study can have such a help to helpers is that instead of sitting around when people do things that just seem completely irrational to us, this puts it in a context that helps us understand that people aren't simply making choices, good choices or bad choices. And when we're working with people to help them change, we need a lot of bolstering up in the effort because it's hard sometimes to work with people when they're not ready to change, which is we're going to talk about in the next section of the program. I think that trauma-informed care, even if you're not in a trauma-informed care organization, even if you haven't adopted a model that allows you to be more collaborative, that allows you to have a more safe environment, even if you're still working with a lot of rules, trauma-informed care approach can change you. And that's why I hope you will all go to the website and actually explore a little bit of the study, because a lot of things will come into view. If you work in human resources, one of your chief concerns is problems like absenteeism and keeping people in their jobs over a period of time, but also how much money in health care the users of the insurance for that group use. And the Adverse Childhood Experience Study informs every single one of those things, much more than just trying to figure out human nature. We want the settings that we practice in to be safe for the people that we provide care for and for us. And we also want to specifically know the individual's trauma history that we are working with and provide care that's individually tailored to that. That is as much a part of a trauma-informed care approach as an organization's decisions about what rules to keep and whether to have a level system, but also to assess each person for their trauma history and make sure that the system doesn't provide more trauma for them. To be trauma-informed is also to recognize that we can be a trigger for other people and they can be a trigger for us. So we won't always work as well with one person as we might with another, and just knowing that is sometimes half the battle, so that we have an opportunity in some cases to let somebody who's more comfortable work with a person. It also helps us in our role as receiving a lot of negative emotions coming our way, but being able to tolerate that and continue to offer unconditional positive regard back to the person. Sometimes in an everyday world where a person has to work 40 hours a week constantly with an influx of working with somebody who's negative, that can wear a person down. The trauma-informed care approach allows us as the providers to have a little bit more empathy and energy for dealing with a difficult person. I find that all people, whether age 2 or 92, do better if they are asked to do something than if they are told to do it. And using this kind of approach, we seek to provide as much self-determination, self-control, and self-restraint as possible. And that is different from a traditional approach. In a traditional approach, we've often said, especially in nursing, you have kind of let your life get out of control. Let me take control over for you. Let me run things for you. I'm an oldest child and a very bossy person, and I often tease that, believe me, I know what's better for you. Just let me make all your decisions for you. And nursing in a hospital sometimes has taken on that role. And I wouldn't speak for medicine or social work, but I think sometimes it is easy to think, well, you've let things get really out of control. Let me take control over and help you make decisions, this medicine, this group, this lifestyle. And a trauma-informed care approach gives the individual a lot more latitude than what we have traditionally done. Sometimes that's not easy to do. I'm hoping that what we talk about in the next section with the change model will shore up your ability to do that. So I think that probably that brief little overview of trauma-informed care is created some questions, and I want to give us a little pause to just let you make comments or ask questions about the trauma-informed care. Just brief. This is like a very beginning overview of it. No questions? You still can ask me questions about it later. So we're going to talk now a little bit about knowing what we know about people's risk from the Adverse Childhood Experiences Study, knowing that people are physically at risk as a result of their childhood trauma history. What kinds of choices can we help support in them that will help them be physically healthier and mentally healthier? And this is not this is all based on research. None of it is edgy. None of it is from fringe science. These are all things that come out of information that is available to everybody through the American Heart Association, American Cancer Association, American Dietetic Association. So there's tons more things that have to do with a therapeutic lifestyle for heart and mind, but these are not those. These are the ones that you can feel comfortable recommending for any person. Sometimes I get a question at the end and someone says, well, could a person with diabetes do these things? Yes. Could a person with chemotherapy do these things? Yes. These are the safest health advices that you can give to a person. Nothing that you would have to feel needs to be individualized. These are things that we can tell people to do without really having an incredible assessment of their health histories. These are good things for all people to do. With an assessment of someone's health history, we might be able to tailor even more which thing we would get them to do first and which second, and on like that. So we're going to cover these things really quickly and then take our break so you can shore up on snacks and water after just hearing about the need to drink water and eat vegetables, and let you have a little bathroom break. And then we'll come back. We're going to spend the whole last hour on the change model and how you can tailor your helping to be the most effective at every stage of change, which will help you not to be worn out. So these are recommendations that we all know and probably follow part of the time or maybe all of the time, or we may need to do work here because caregivers are sometimes super good at giving and not as good at taking care of themselves, but everyone can benefit from these recommendations. And my favorite website is listed in your handout, and it's from Kansas University. They actually have a website called Therapeutic Lifestyle Change, and it's about, it's a summary of all of the items, and it's not long, and it's super layman friendly. You can recommend it to any of the people that you work with. Even a preteen could probably work their way through this website. It's so accessible to provide great recommendations. Not everything on this came out of that website, but that's just one of my favorite overall. If somebody's starting from scratch and they say, what's a good wellness program to help a person who wants to have a better mood and have more energy, this is a great website. It is tailored to people that are dealing with chronic mental illness like depression, but not just depression, but it's very accessible to somebody with depression. So this is my prioritized list. I started working with people in the topic of health choices and wellness all the way back to the end of the 90s when I was in the Navy, and it was a very fun, exciting time, and a time in my life when I personally went from a couch potato to a marathoner in the very last 5 years of the 90s. And it changed my life considerably and helped a lot of areas like eradicating migraines and a bunch of things that it did for me that put me on a path, just like a lot of people who quit smoking. They want to help everybody quit smoking, and people who quit drinking help people quit drinking. And so this has been a sideline and a passion of mine, and I've given, some of you may have been with me out in the community where I just talk about health choices only for the whole 2 hours and not other topics. But in behavioral health care, I truly believe now that we have integrated care, we are looking at bringing the experience of going to the primary care doctor and the psychiatrist together in one place, and we're calling that integrated care, and having them talk to each other and interact and provide a more holistic experience for the patient. But really, we have to even take a step back and think about how we can help people be supported to make the kind of health choices that will mean that they will need a minimum amount of primary care, that their care will all be primary. Primary care is the care that you get before you're sick. It's not just what kind of doctor provides you with health care. Primary care is the care that you get that keeps you well. It's supposed to be the care that's free in your insurance plan. It's the wellness type of care. Wouldn't it be great to get through a life and that would be the only kind of care you would ever really need? That would be an awesome world to live in. What if that was the world that we lived in? Would be amazing. So these are the kinds of health choices that we can encourage and support, and one of the ways that we encourage them is by practicing them ourselves and see how they work. It gives us the ability to share with other people, and that's going to come in really handy when we talk in the next section about how we help people change. Because even if you don't want to change, don't you want to change some other people? It's fun, right? It's much more fun to work on other people. It's just way easier. So we're going to look at it from both perspectives after the break. So this is my prioritized list. If I could only get people to do one thing, I would get them moving and start an exercise program like walking. And now here in San Antonio, we're on that path, thanks to many awareness events from the Mayor's Fitness Council and other great interested parties, and the San Antonio Business Group on Health. So we've had lots of big players that have helped us become more aware, but we're not all there, right? So when we talk about change, I'll be giving you some tips on how to get started. We'll use a walking program, or starting an exercise program is one of the things that we look at. And getting enough sleep per night. It's really nice that now we're getting lots and lots of kind of public media attention on the research about sleep, because it's really important in terms of, we get it from the media because people who don't get enough sleep cause car accidents and mishaps, and that's kind of the downside, except now we all know, hey, we can give ourselves permission to sleep enough, which is at least probably 7 to 8 hours a night for everybody, not just for healthy school children. And that gives you a motivation, hopefully, to go to bed on time at night. And then it's easier, much easier, to stay awake during afternoon presentations on Friday.